Good afternoon. I'm Vishal Peshattiwar. Uh, well, minimal access TLIF or MIS TLIF with percutaneous screw fixation. All of us know this grade 3 listhesis requires a fusion, and this is pretty much standard what you would do for a fixation for this case. But if you could manage to do this with this barely discernible scars and that clinical result at 1 month from surgery, well, that is a technique that's worth learning. Our journey started with this logic. My boss explained it to me. In an open surgery, if you put a retractor, what you can see here on my screen here, that's the amount you can retract. So your vision is restricted to that much part of the spinal canal. Whereas where you were to use a tube, go a little on the side, and then use an endoscope or a microscope to view, your vision increases much more. It gives you a much wider scope of vision, a telescopic vision. And if you're not satisfied, you can always dock your tube from the other side. That's the whole logic of having better vision in spite of doing less damage to the skin tissue. Well, how do you go about it? Well, you have to be very precise. This is a non-forgiving surgery. If you don't plan your portal correctly, instead of the midline, what you need to do is go about 2 to 4 centimeters lateral to the midline and go towards the facet joint of the index level you wish to address. It has to be exactly in line with the disc space to give a correct docking so that you can do your job correctly. Well, put in the dilator sequentially, move it in all the planes so that, like a periosteum elevator or a cob, it will take away all the muscle away from the bone and not damage it. And this also prevents muscle creep from happening from the edges. You serially dilate the muscles so that you don't damage. At the same time, you make way for a tube to be inserted. That's a quadrant tube. This pictures are nearly 14 years old now. Once the tube is docked, it is always prudent to check which level you have docked, because L4 and L5 have the same entry point. It's just a question of angulating your tube by around 15-20 degrees to reach L5S1 and going straight to reach L4. So if your head end is high, you're very likely to go to the wrong level. So always check where you are. Once you know you're at the correct place, then you go ahead. See, this is the schematic drawing, but we rarely see that when you go in real life. That's the real life view, what you would see through a microscope, viewing into the tube. A facetectomy, that's a schematic drawing again. That's the exiting route, that's the traversing route, that's the disc space. But in real life, this is how you will see. That's the disc, that's the exiting route, and that's the traversing route. That's the nerve root retractor holding that traversing route at bay. Well, this is a small video to give an idea of what an MIS TLIF is. This was recorded in 2009. I mean, it's very much still the same. The principles haven't changed. This is an L4-5 instability with stenosis. I always mark the surface to let me know what the landmarks are. As you can see here, I'm marking the pedicles here. My incision is about 3 to 4 centimeters lateral. I use a small hemostat to open up the muscle, serially dilating on the bone in all the directions to release the muscle from the periosteum, and that's the tube docking in. Once that's done, the retractors come off. You have to check the level at this stage. This is the correct level. Initially, you can use expandable this retractor. This is a quadrant third generation retractor from Medtronic. It has got cephalocaudal and mediolateral retraction. You need to take the muscle that is attached to the lamina here, and that's the view. That's the facet joint. That's the head end. That's the medial part. That's the foot end. We used to use landmarks to put in our screws then because they were cheaper. So that's what I'm doing here. After this, I'm doing a facetectomy. You can use a kerrison, you can use a drill. I use a chisel because it gives ready autograft, which is very, very precious here. And that's the facetectomy again. That's the hole I have made to pass into the L4. That's the hole I've made to pass in the L5. That's the medial, that's the lateral, that's the head end, that's the foot end. That's the ligamentum flavum, which we are going to take away. I'm using a 3-0 lumbar curette to separate it from the dural tube there. A little bit of lateral laminectomy to get more bone graft. That's the dural sac. That's the disc. That's the clarity of vision you should expect if you can see the disc being cut very clearly with a number 15 knife, various instruments. You have to spend time doing discectomy. If you want it to fuse, you have to prepare it correctly. There is nothing like put in a shaver, rotate it and put in a bone graft. Doesn't happen. You have to use curettes, you have to use rasps in opposite side, the downward side, the undersurface of the annulus, the opposite side of the annulus, so that you can get as thorough a discectomy as you can. We used to use rasp to open up the bony end place. We don't use that anymore. We definitely take a box cut so that you can put a right size cage inside. This prevents undersizing of the cage. That's the trial. Initially, you should always trial and see that you are putting in a right size cage there. A bone graft has to go through a funnel so that it reaches the correct area where it is to go and does not go away from the intended interdiscal space, intervertebral space. I again use a trial to make way for a soft peak cage that goes in after that. I personally prefer a bullet cage. You can use a banana cage if you prefer that. That's the cage securely inside. Over the top decompression has already been handled previously, so I'm not going to go into the details. But yes, this is what you should expect. We usually tilt the table to the opposite side and then go over the top to do the decomp to the opposite side and confirm thoroughness of the decompression with a 3mm ballpoint probe at the end of the surgery. Well, that's the TLIF part of it. How do you put a percutaneous pedicle screw? There are certain things you should have without which you should not venture into doing a good, doing a percutaneous pedicle screw. A very good quality C-arm, a better trained technician, because having a technician is changing every 6 months or a year is going to be very bad for you and your team, because the radiation exposure is going to be phenomenal. You need a good quality radiolucent table. You need radiation protection equipment, because it's very common to get cancers associated with excessive radiation. Well, one of the ways of putting screws, as you saw in the initial part of the previous video, is to use classical landmarks to do it. This is beyond the purview of this lecture. Well, all of you must have done vertebroplasty sometime or the other. The principle of a pedicle screw percutaneously remains the same. You have to understand, like very much like a vertebroplasty, if you have marked your pedicle lateral border on the skin somewhere here, you cannot start from that point to get inside, because your needle has to travel the fat, the muscle, before it reaches. So if you start at the point of the lateral margin of the pedicle that you marked on the skin, your needle is more likely to skirt the medial border of the pedicle. So it's always better to go 1 to 1.5 centimeter lateral to the lateral margin of the pedicle, and then take your incision. Nowadays we go about 3 to 4 centimeters to get a really lateral entry to our pedicle screw, but at least 2 centimeters lateral to the lateral border of the pedicle will ensure that you get a correct trajectory. So try to go a little lateral to the lateral mark. That's what you expect to as a correct one to get in. A screw that is going very straight will always impinge on the proximal facet. So your ideal entry point, as you can see on this image here, is in the outer quadrant and at 3 o'clock position, if you were to think of this as a face of a clock. So between 2 to 3 o'clock position is an ideal entry point for your Jamshedi needle. A lot of us think, why not put it more superior so that it's away from the exiting route? Well, my friends, you have to understand there's a facet joint there. And if you go any superior than a 2 o'clock position, you are going to have your tulip sitting on the proximal facet, which is unfused, and you're going to get proximal level arthropathy. So you need to be very careful about where you're entering. Another trick to remember is, I'm using this picture-in-picture image so that you'll understand this. So when this needle in the lateral projection has crossed the base of the pedicle, as you can see here, this has crossed the base of the pedicle, but it is still inside the medial border of the pedicle on AP. What this means is this needle is inside the pedicle and not in the vertebral canal. So this is one step. If you understand this, passing a pedicle screw via MIS technique is easier than putting an open pedicle screw. Remember, If your needle is still somewhere at the start of the pedicle and it's already crossed the midline, you're going to enter into the vertebral canal. So this is where you have to be very, very careful of your Jamshedi needle positioning. To reinforce again, your needle should have crossed the base of the pedicle, but still be contained within the medial border of the pedicle here, which means you are safely inside the pedicle and you can go ahead with the surgery. Once your needle is in, you need to put in a guide wire. This guide wire should not cross the midline, because if there's anything dangerous in passing a pedicle screw or in this entire surgery, it is this guide wire which, if it travels along and perforates the anterior border, it can injure the vascular or the viscous structures inside the abdomen. Once the guide wire is in, you need to tap. We used to tap right to the tip. Nowadays, we just tap the pedicle and come back out again. This is a small video. The hemostat here is marking the pedicle lateral border, and you can see my incision. It is about 2 centimeters lateral to that. I would recommend you go now 3 to 4 centimeters lateral. Put in a finger, feel the lateral aspect of the facet joint there, and then take your Jamshedi. Check this on the C arm, where you can see my entry point is 3 o'clock position. I banged it in. Now I'm checking in lateral. It is not, it's gone beyond the base, but it's still contained in the pedicle. That's when I put in my guide wire. Once the guide wire is put in, you use serial dilators to go over the guide wire. You have to seat this dilator right over the transverse process and pedicle junction at the lateral aspect. And once this is done, then you put in the final dilator, take out the inner dilators, and start tapping. You have to check initially that they are sitting perfectly. With the practice, it's going to be okay. While you're doing this, have your assistant or you yourself hold this guide wire so that you know it's not traveling with the tap. If it travels with the tap, then you will have trouble, because it will then reach the anterior cortex and give you problems. This much tapping is enough. In fact, you can just go beyond the pedicle and stop. This is what we used to do about 13 years ago. While taking it out, have somebody hold it so that it doesn't walk out with the tap, because putting it back becomes a problem unless you have navigation. So that guide wire now is in place of a track that is going to take the screw. So that's the screw going in. Be careful. Make a generous incision here that is wider than the tulip of the screw. Otherwise, you'll have your and purposely doing this, we try to keep it small, but then that takes your adhesive drape inside, so you don't want to do that. Once your screw has passed the pedicle, you can take the guide wire out and then pass the screw inside. Be careful that there is no adhesive drape that goes in at this stage. I prefer to take the adhesive drape nowadays. It has to go down completely. You have to see the screw right there on the pedicle. The next pedicle screws goes in similarly. The only thing you have to ensure is both of them are at the same level or in alignment, so that putting in a rod becomes easy, and it is not difficult, because if they are not at the same level but at different heights, then putting in a rod becomes very, very difficult. Well, that's the alignment you need to put in a rod at that place. You have to understand that every vertebra has a different alignment when the patient is on your operative table. So you have to be aware of these alignments. The best way to look at this alignment is to take a pre-op lateral image to see at what angle which pedicle is going, so that you can plan your incisions accordingly. Well, other way of passing the screw is to use navigation. We at our place use an O-arm. You can use C-arm based 2D navigation too. Once you have an image, this data is fed into these two navigation monitors that you can see. What essentially navigation is doing here is, I'm marking this on the skin. It is projecting that blue thing is the projection of that true needle, and the yellow is the projected tract it will take. So I know the part on the skin where I have to take the incision, and that's where I mark it. So that's how the marking gets done. Then that's how the incisions get taken. That's the skin incision taken. My needle is projected here. That's the blue part, is the needle there. In real time, I can see it advancing. So I know where I'm going to pass that without having to cut or expose myself to radiation. This is where it sits on the bone. Once it's on the bone, you can check the exact length of screw that you're going to pass inside, and then start banging the needle in. It will reflect real time in the console as to what you're doing, and then you follow the other steps follow like that. Well, that, my friends, is how to do an MIS TLIF. You can see
Wow.
here, this is an open surgery, that's an MIS surgery. None of the muscle here is damaged. That's the beauty of doing minimal access surgery. Thank you.